abduction, and otherwise an closed intramedullary fixation with this prevents rotation, and generally you will give earlier elbow movements and other movements. It gives you a very satisfying result. But if you look at it properly, all of this will require one incision at the top, two incisions for the two screws on top, and one or two incisions below. And if you add up all of it, it may come up to be equal. So be careful. It looks elegant, it behaves elegantly, but as matters of cosmesis, it may be not too good. So this shaft humerus, the major problem that came about with the plating was the radial nerve. While we know about the radial nerve, where it is and how it is, but any interference with it causes a very dissatisfying radial nerve pulse. And then you have to be very careful about it, how it's going to recover, when it is going to recover, it keeps late. And your patient will come back at you, saying that my wrist doesn't get up after the operation, and all sorts of problems. So you have to be very careful knowing that whether it's recovering or not, know the anatomy, which muscles come first, and how they're coming. You can do lots of investigations and all that, but the best is the clinical one. And in the clinical one, you find out whether your extensor carpi radialis brevis and longus keeping on working, and then later on find out about the others as the nerve recovery progresses. So Holstein fracture, which came about, the lower 1/3 humerus fracture, which came about with this, was settled very well by this developed plate of the dorsolateral plate. And that worked because the lower screws that were there were all locking screws which had come into being. And you could do the calculations, the variable angle calculations, and therefore put your screws exactly in their place. But again, remembering that the more proximal you get, you have to be very careful about the radial nerve. So shorter conventional plate was the ones that we used in previous years, but that has been replaced by these sort of new plates with the new locking screws. And supracondylar fractures that happened, we all tried closed manipulations, and this sort of fixations were often carried out. It went on to unite, but with some sort of deformity. But the other supracondylar fractures, this closed pinning came into being, especially in the younger age group. And there were controversies whether you should give lateral K-wires or medial K-wires or both, etc., etc. But we always found that the two lateral K-wires was good enough in most of the cases. There were other ways of fixing this fracture by from top, from bottom, from both sides. But generally speaking, this sort of K-wire fixation held good. The olecranon was all again another, and the tension band wiring of the olecranon was one of the principles that we worked on. And remembering that the two K-wires have to just get out on the proximal part of the ulna below the coronoid, and the figure of 8. And there were various methods, the figure of 8, the circumferential and the figure of 8 combined, and others. But this sort of thing mainly held on. Another fixation of this sort, and this you have to be very careful as to how you're going to fix it. And one of the fixations was by the olecranon. We used a trans-olecranon approach in these cases. Some might use one of the other methods of doing a sliver of the olecranon and getting away with it. And this side, we used a dorsolateral plate. And the medial side, we felt it was good enough to use a screw. And it worked. But that doesn't mean it's going to work all the time, because the standard of fixation here is by these two plates, or the 90-90 fixation, with intercondylar screw and a trans-olecranon approach. So you have a medial plate going on the medial side and a posterior plate which is going on the lateral side. The Monteggia variant with ulnar shaft fracture and radial head fracture, this was where the ulnar shaft fracture was fixed. The radial head was found reasonably okay and stable, so it stayed on. And so this sort of plate has come about in a big way, and most ulnar fractures are being fixed with this. And the fracture, both bone fracture, the standard of treatment is, of course, plating. But we differed, because plating meant that there was extensive dissection of the fracture site, a lack of blood supply. So we preferred doing the old-fashioned method of the closed locking of the closed intramedullary nailing. This case, so this was the fracture. It was fixed, got infected, taken off, and this is what it resulted in. We did the old-fashioned treatment of the closed interlocking, not a closed one, because we had to go in and debride the wound, but also a nailing from both sides with the interposition graft of the old-fashioned decoll graft, and later which went on to union. So close nailing in both bone forearm fractures, we presented this case in the Indian Orthopedic Association of 115 cases, and it's quite standardized in most cases. Sorry. The different types of Montegia fracture dislocation which takes place, we all know about it. And there are Montegia variants also. But again, the ulna has to be fixed and the radial head reduced, held in position either by a K-wire or by annular ligament reconstruction. So shoulder and elbow fractures come in a variety of trauma situations. The advantage of it being non-weight bearing is countered by the need of complex movement sequences of the elbow and shoulder. The real function of the shoulder and elbow is this, what I was told by one of our professors, is to place the hand in an optimum position. I think Ravi approves of that. Most of the times there is need for stabilization and restoring anatomy, and the message is to stick to the latest available technology with the application of the latest technique. We are all looking for function and we are all looking for good results. I will move on to the next talk immediately because there's no point in waiting time. Can we, there is...
Any questions? Okay, there are some online questions. Will you please focus on the role of nortriptyline, gabapentin, duloxetine in low back ache? Oh, this is previous one. We leave this for the time being. Conservative with 100% displacement and skin tent can't be implemented. So I think it's about the clavicle fracture.
No, yeah. When there is a skin tenting, the choice is of doing an operation to reduce the skin tenting. There's no question about that.
Keep the door closed at the back.
Yeah.
Yes, yes, we can start.
So as I said, Aurangzeb is a good friend of mine. So he has now, I'm asked to condense the femur fracture, which is a result of a conference and a book. It's the books, etc. But anyway, let's get on with it. So basically, the femur is the strongest and longest bone in our bodies that we know about. And you can see the different parts of the femur, and every part can fracture, which is the funniest part of it, or the most important part of it. So the fracture neck femur, the most common and difficult fracture, it's still called the unsolved problem, not only by us, but all over the world. Because non-union, avascular necrosis, malunion, deformity, and shortening are all associated with it somehow. The femoral blood supply is one which has been extensively researched, and we know about the femoral blood supply. There is a medial circumflex femoral, lateral circumflex femoral, and they join together. The main thing is that vertical vessels from it go up to the femoral head. And these vertical the vessels are end arteries. So if they are damaged during a fracture, the chances of getting an avascular necrosis or non-union is very high. And we know from the time it's from the childhood from 4 to 7 years, the epiphyseal plate is a firm barrier. From 9 to 10 years, the ligamentum teres vessels become prominent, and the anastomosis with the lateral epiphyseal vessels, and later on, and later on the vessels resupply once again, but this is the junction area where Perthes disease takes place. The adolescent period, of course, there's extracapsular arterial ring, there's ascending cervical branches, there's artery of the ligamentum teres, the epiphyseal blood supply, and the metaphyseal blood supply. And this is what it looks like when a growing bone. The vessels are going into the epiphysis, the vessels are going from the metaphysis, and we all of us read about it in our medical school. And when the fracture occurs, these are the end arteries of the Truetta's very famous paper looking at the end arteries which are damaged by this fracture and which may lead to the avascular necrosis and non-union. So the first treatment is recognition there's a fracture neck pain. And early operative treatment within 6 hours get the best results. And that is one of the problems that we face in our country. Very often you will find people coming after 1 day or 2 days. And it is this area where there is nothing to be done excepting a social change in which a fracture neck pain is detected and sent to the appropriate center. Closed reduction and fixation remains the operational choice. 3 cannulated corticocancellous screws still remain the treatment of choice. And if necessary, do not hesitate to perform an open reduction and fixation. And if you do that, you can do it by lateral approach, you can do it by anterior approach. And if you want to supplement it by muscle pedicle bone grafts, you can go anterior, you can use the tensor fascial lata muscle pedicle bone graft, or less better, or a little bit worse is the sartorius muscle pedicle bone graft. And if you do a posterior approach, in which many great work has done in Calcutta, of the quadratus femoris based muscle pedicle bone graft, which has given increased vascularity to the area. So the closed reduction and stable fixation, there are classifications. The Garden classification we all know. 1 and 2 is there, 3 is displaced, and 4 is more displaced. And there's a Powell which gives you the angles, so 30 degrees, 60 degrees, 70 degrees, making it worse as the fracture becomes more vertical. And there's the OTA classification. One thing we have to see about the Powell's classification, is often quoted, is that this is an APP only. And these fractures are never linear, it is spiral. So in an AP view, if it is going in one plane, if we do a proper lateral view, you'll find it going in a different plane. So it's difficult to classify it by Powell's fracture. So femoral neck fractures are intracapsular, placing them at high risk for non-union and other hip fractures. They lack periosteal or extraosseous absence. They are bathed in synovial fluid, which deters fracture healing, as you know from experiences from the other parts of the body. The healing is intraosseous only. There is no callus formation unless it's a displaced fracture which is uniting. And achieving and maintaining anatomic reduction is essential. Either you do it by the closed or the open method. So these are the cases which we jumped onto, got it early, and then did these corticocancellous fixations. And remember, this fixation that was done there was done in the V pattern, that you have 1 screw on the top and 2 parallel screws at the bottom. Now this resulted in a problem which was said, which we never faced, is that this cortical 2 screws going inferiorly damaged the cortex at that point, and that led to an increased incidence of trochanteric fractures. So this fixation was changed from the 1 and 2 below to the other way around, or a reverse V. And this is a reverse V which also works almost the same way. So the BDSF technique then came about. And the real issue here was, should these fractures collapse to unite? In the previous example that we showed, the fractures collapsed, they were allowed to collapse, and they united. In these cases, the new therapy is that fractures should not collapse. And that is why you have this BDSF technique. When 1 screw goes obliquely, the other 2 goes parallel, you don't want collapse, and they still unite. The other ones that are coming about is a metaphyseal nailing system, which is works in this way, as you can see. This is experimental still, no clinical support. So DHS with accessory screws is one which we have all used. The parallel 2 screws preventing rotation. And this was good ones which also unite in many cases, but again, not at all. Because again, the collapse also was not very good. And then people started getting excited. We also now started doing the radial buttress plate on this. So 3 corticocancellous screws, and on the inferior side, you do an anterior approach and put in a buttress plate on the inferior surface. Again, experiment. And then the femoral neck system came about, the FNS, So this had advantages of the DHS and the cannulated screw. There were no insertional torque, the compact design, smaller incision, and generally higher resistance to varus collapse compared to fixation with 3 cannulated screws. An implant collapse does not result in lateral protrusion and soft tissue irritation. So the FNS system is also being used nowadays, but we still have to wait a long time to see what it works in different hands. Perhaps in few of the perpetrators it works well, but then in the general public, let's see how it works, and we still have to wait. And the other ones that were there, the hemiarthroplasty, cemented on cemented stems. We used cemented stems initially. We used uncemented stems in the sense that we used the Austin, Moore, and Thompson and all. But they were not really uncemented stems in that way. It just didn't have any way to put in anything. So the hemiarthroplasty cemented ones were used and got its great followers all over the time and still works in many cases. But we found great difficulty in removing them if there is any problem with this after 5 or 7 years. And then came the uncemented stems, which led to a lesser incidence of thigh pain. It used to work more and work longer for some time, yes. Then, of course, a dual mobility cup came in, and this is a standard therapy nowadays for many, where you suspect the dislocation may occur, and the cemented hips and the uncemented hips, which all has its advocates and it all has its followers. One of the easiest classifications we learned when we were studying for the MS exam was the Fielding classification, in which you just see 1, 2, 3 on the left-hand side, and that was easy to understand. But the other one was the Sennheiser one, and the other one was the AO OTA classification. So A1, all sorts, and I won't go into details of this. This is not the time or place. The treatment, we learned first the art of traction in our younger days. So any ways of this trochanteric fracture, we used to put in traction. A pin to keep it well, to fix it with plaster, and rotation, how much weight to give, what should be the height of the foot end of the bed being raised, all sorts. We learned a lot of things, and how to put the pin in such a way that the foot doesn't remain internally rotated or externally rotated. How to place the strings of the pull with the weights. So all this done, we used to rely on the portable X-rays and the mobilization of the other organs. So many had bed sores, lung and urinary problems, malunions, delayed unions, but many healed and resumed their previous lives. And this is perhaps a reflection of the society in which we live, where the fracture infection rates are almost none, and the good care by family members were developed. And nowadays, you won't find that standard of family care. So then the implants came, the blade plates, the fixed angle plates, McLaughlin, Jewett nail plates, and then the DHS long plates, and we've used them all with various degrees of success. But one thing was big incisions, and the chances of infection were there. So the revolution came with image intensifiers being available at low cost, and the availability of closed reductions and new implants like intermedullary locking nails and the dynamic hip screws. A lock time nail has this advantage over an unlocked nail. Higher union rate, lower incidence of immediate post-op malrotation, shorter OT time, less radiation exposure, higher rate of maintenance and reduction. The shark femur has many classifications in this nature, but all of them are revolutionized by the femoral blade. And you have dynamic holes in it. Stability was achieved by the static locking screws, and it was an art of when to realize to convert this whole thing, put the dynamization effect into principle, and that was also a part of the learning process. And then the self-drilling, self-tapping screws came about. There was a good purchase in osteoporotic and metaphyseal areas, so that again was another revolution. And we had the AO classification and the OTA classification for the lower, especially for the lower femoral fractures. So there were locking screws and variable angle plates, distal femoral nails, distal femoral plates, variable angle locking screws, all sorts, cancellous locking screws, variable length, the distal threaded screws, and we have them all now. So we are more biomechanically compatible with whatever fracture is given to us at what time. So these were the plates, the lower femoral plates, the screws, and you can see on this the variable angle areas in which the screws can be put in. And again, these also, the distal femoral nail, in which you can use a bolt at the bottom and then 2 screws at the bottom, or whatever. And this is mainly for the supracondylar A1A fractures. So these were the plates that were put in at this time, and they all did well. And this sort of, this is a case in which you can see a sharp femur fracture treated in one of the peripheral hospitals in West Bengal. A plate was done, it started bending and breaking, went to another hospital in the south where they did remove the plate and put in a similar plate of a bigger length. Again, that broke. And then it went on to another, they did another plating and again that broke. And so when it came to us, we did this, we had to remove the plates. So we did an open reduction, we did an interlocking nail. We went back to the old-fashioned principles of bone grafts, copious bone grafts, and you can see the fracture has united, and I hope this works. Yes, it will. So you can see the amount, but it took him 3 years. He was 26 years old, a budding engineer, and this is how he finally ended up with and could really go back to his work and his profession. Fracture neck femur, what to do when it comes late? This fracture neck femur has come to you, you will do an open reduction and fixation. But in these, what we did, where the neck was absorbed, we thought of a different way of doing it. Put in grafts, and the triangular graft from the iliac crest was taken. The graft was prepared, drilled, multiple drill holes made through the thing, preparation of the graft after final preparation being placed in the prepared fracture site. This was what it looked like. I'm doing an open reduction into that area. So the graft placement was adjusted, and remaining gap at fracture site was filled with bone graft, and this is how it looked like at the end of the operation. And the graft secured with a guide wire gradually went on to multiple guide wires, and fixation was done with 3 AO cannulated screws or nose springs. And this is how it turned out to be, with good neck restoration and therefore less shortening and improved function. So the results. We did a series of these cases, about 25 or 30, we presented at IOA also, and this has now become one of the parts of the treatment of delayed neck femur fractures. So femur fractures present a bewildering variety of problems. You have to be quick, you have to be innovative, you must have a huge number of choices, but stick to the basics, the current principles to gain success. You're all students, postgraduate students, and you're like birds in the sun. And this is how you pick up and go along. And this is in short, a very brief short. Thanks to Orindo for this.
Two questions. One is non-union rates in nailing versus plating in humeral shaft fractures. Your view?
My view is that the interlocking nailing, because of its earlier return to function, and the non-interference with the peripheral blood supply of the fracture site is much better.
Okay.
Less non-use.
Okay. I just add a comment to this. We did an audit because I was associated with nails. So we did a nails audit in this hospital. And we found that of all the nails we did, of all different parts of the body, the highest complication rates were with the humerus. One of the reasons I think was that the nails we had were not, very suited for the lumen of the Indian ladies. So anyway, after doing that audit, we actually changed our practice and we shifted back to plating. So I do a lot of, plating more than nailing than before.
Well, that's a big controversy. We do a lot of more humeral nailings than platings, but nowadays we do get appropriate nail sizes for this.
So you can read.
And there are many subtle things in the nailing systems which one has to be very careful about. And once we follow those principles, we do get less humeral non-nails.
Just a comment, if I may make it. It's a very broad comment. it's not just only about the arrows you use, it's about the archer using the arrows.
Yeah, yes, absolutely.
Okay, next comment, next question. Can we use tense nail in adult fracture of the radius and ulna?
You can use tense nail. It is not bad, but remember it's a closed nail. You keep the reduction right. So you can use tense nail. We've used it a lot, but we prefer, due to cost systems and all that, the lesser square nails or the lesser intermedullary rush nails. And they do fairly well.
The diameter is very important.
Yes.
You have to choose the correct diameter here. Because most of the time we see, nailing is an art. Indra has perfected it and he's been doing it, and we've been seeing it since our PG days. So it's very easy to stick an undersized nail, a tense nail up a forearm, and then blame it on the nail and say it's not work. Because, like he said, you have to follow all the principles to get a good result.
Okay, are there any questions from the audience? If not, then Indra, thank you very much. And I'm sorry you had to cover a lot in half an hour, but actually we were told the target audience was a little different, as you know. We've been going back and forth on that. Okay, I now invite Buddhadev Chatterjee. Buddhadev, as you know, he is one of the high performers